and to look to see where that lead is. And if we like where it is, we're good. And so we've done a lot of studies looking at that, and our outcomes have been very strong in that regard. But it's still, I don't think one's better than the other. I think it's more kind of, it's gotten to a point, it's almost like surgeon preference. You know, if somebody's a high volume surgeon and they know how to target well, the assumption here is that when I say, if I hit this spot or, you know, somewhere around this, that we're going to get a good result. The assumption is that the surgeon's picking the appropriate target. So that I like this spot right here. Say, for example, I decided to go back here, right? A little bit further back, maybe like 3 millimeters off, and then I got like a 2 millimeter error posteriorly. So it doesn't matter that I, you know, hit my target or got close to it. I'm so far off that we're unlikely to get good results. So the key here is knowing your anatomy, knowing where you want to go, picking that target, the assumption being that that's the right target, and then hitting that target within a couple of millimeters. That's my goal. But similarly, you know, seeing the cellular recordings, observing the tremor stopping at surgery, seeing the rigidity melting away, the stiffness, you know, those are other surgical endpoints that are assessed at the time of surgery. So these are all kind of what are the appropriate surrogates to predict how a patient's going to do, you know, 6, 12 weeks after surgery. You know, and in this case, we're kind of leaning upon the data acquired through decades of awake surgery to inform how we look at this MRI and how we choose our target on that MRI. All right, I'm gonna go prep. Yeah, check, double check, triple check all our coordinates. We're good with our 3 minutes. Let me turn around quickly there. Okay. Oh, come on. Right. Good. All right, we're draping our patient now. And this is very similar, this style of draping that you would see in an awake surgery. Although the patient would not be flat, the patient's back would be slightly up to facilitate breathing. And that's one of the features I like about this, is that the patient's still in the flat position just like they were for their MRI before the day of surgery. Okay. All right, contaminated tip. So again, we kind of had a dry run already, putting together all of our coordinates, and that dry run was just for the haircut. Okay, all right, looks good. Check our coordinates here with Dr. Chua. 84.9, I think that looks good. Great, looks good. 75.8, good. 20, So here we just always double check each other. At least 2 eyes at all times, checking the coordinates. 120.8 and 97. Okay. All right. All right, you're good over there?
Yeah, we are.
97. Yeah, 120. All right, good. All right, you want to go ahead? Yeah, I placed the X. Oh yeah, I did. I checked it.
Okay.
Yeah, I didn't do it. Yeah. Okay, ring is 68. Let's go ahead and countersink. A little countersink. Yeah. Okay. All right. So this is kind of what we did roughly earlier, but now this is a more precise manner for identifying that entry point. So that's our spot right there. Okay. Looks pretty good there. Let's see. Okay, here you go. Specimen cup. Yep, looks good. All right, yeah, so you can see here again, the whole principle behind this frame, aside from squeaking, is that no matter where this is positioned, it's going to be pointing to the target. So we can slide this thing back and forth, we can slide it up and down, but it's always going to be pointing at our target. So the only coordinates that we're dealing with now are determine the trajectory. Okay. Stapler. Okay. And local, and then for our pause, we got to watch patient privacy. All right. Okay, great. Yeah, let's go ahead and mute it. We're about ready for that. Okay, yeah, so in that timeout, we basically stated the patient's name. We stated the surgical site, what the operation was, what side we're on, what site we're targeting. And we estimated the length of time that this would take and what our estimated blood loss. So at this point, everybody who's participating in the operating room stops what they're doing. All thoughts are on, what are we doing today? And make sure that we're on the same page. All right, so we're going to start. So this is a flap. So here we'll have a little bit of bleeding. It's okay. Take this. Bobby. The scalp is incredibly vascular. That's why it heals so well. Okay, see the rain clips. Okay. Gonna take a snap next. I got Sylvia as my scrub. She knows my every move, so let's go very nice and smooth. Okay, make a little pocket for later. So this is where we're gonna be tucking our wires for the next part of the operation where we bring it down the neck. Let's see the bovie again. Okay. All right, Wheatlander. Okay, so we're through this scalp. We're on the skull there. Got a little squeak. So this is our third time going to these coordinates. And the goal here is just to really make sure that once we're all the way through, we're entering where we want to enter, that we're not missing it. Okay, let's see the suction and the drill. Yeah, straight to periphery. Okay. All right, this is a perforating drill. Basically, is what's used to make the that little hole about the size of a dime. And it's got a little clutch so that as soon as it meets no more resistance, it disengages and stops. The little sound right there is the inner table. We're right about at the end, and then stops on its own. Okay. Let's see a curette. So what's left behind after that drilling is a really thin sheet of bone. So I'm just kind of clearing that off right now. That's good. Okay, flow seal. That's our little magic stuff. Stops any bleeding. Then let's get the stem lock. Let's get the magic stuff again. Oh, okay, bipolar. Okay, that's good. All right. Yeah, let's start a stem lock. think we're good there. What's that? No, yeah, we're good. Okay. Yeah, we can do that. Let's do the pencil. That's fine. Okay. All right, we've marked this out. We're just going to drill down the bone a little bit because you'll see the little device that we use to lock the wire in place in a manner that doesn't crimp the wire but secures it, leaves a little bump. Okay, so we're just drilling down the bone a little bit so that the little platform that we use isn't sticking up so much. There we go. Okay. So this is called the stim lock, and it's a device used so that once we have our wire where we want it to be, it doesn't move up and down, but if you squeeze the wire too tight, you can short it or break it and get open circuits. So this is designed to be kind of Goldilocks. Hold it not too loose, not too tight, but just right. Okay. All right. All right, we're back to 68 on our ring. That's good. Okay. All right, so we start now. We basically want to accomplish this by disrupting the brain as little as possible. So far, what we're looking at the bottom of our skull here, a little hole, is it's called the dura mater, and that's the nice white envelope that contains the brain and all the spinal fluid. So we may see a little bit of spinal fluid when we do this. Okay. So I'm going to use some electrocautery. Okay. Get that hole started. Okay. So we're trying to get a little window past the dura that's not too wide but not too narrow. We don't want it to deflect our path. That looks good. Okay. So that's our little sharp tip stylet. Now we'll use our cannula through which the DBS electrode will be placed. That's good. I don't see any deflection there, so I'm happy with that. And this is kind of that moment in the operation that Everything goes to slow motion. Okay, and our number is 85. Yeah. All right. All right. Okay. And so we're at our target now, and this is the DBS electrode right here. You can see here, this has 4 little contacts. They span 10.5 millimeters right at the tip. So this measuring device, Sylvia set this up for me. It looks good. I double check it. And this is measured so that it'll stop right where it needs to stop. And a lot of this is knowing how all these parts fit together, kind of knowing it like the back of one's hand. Okay, there we go. And then let's get the clip. We're going to check the circuit right now. That's what this little thing is for. Leilani's about to check the circuitry.
Okay, if I expose his mouth, or if I just leave that?
No, you can just leave that. Don't worry about that. This is the clip, so called the Pac-Man. Close that. So that's the first step in locking this in place. That looks good. Mark that. Okay. Okay, we just tested our stimulation, looking to see if we have any motor side effects at higher voltages, and that looked good. Okay, there you go. All right, can we call for CT? Okay, bayonet. Okay. Michelle, go ahead and hold this down a little bit. If you push this down right there, push it down like that. Like, see it, like right there? Okay. Suction. There we go. Yep. Push it down like this. Yeah. There we go. There we go. Okay. So you can see here what that looks like. What I just did, I placed a little cap on top of the stim lock. So this is the device that is both clipped it and then capped it down to lock it in place. And now we're ready for our CT scan to verify lead position. Kind of cover that and okay. All right. Okay. All right. Good. You want me to screw that? What do you think?
depends on how much explanation you want to go
Oh,
into. So.
yeah. What's that? So we're doing. Okay, so what we're going to do now is we're getting our intraoperative CT scan. So the patient's all draped, the lead has been placed. Yeah, we're ready. And we did not move the bed at all, so we should be good. Hot mic, hot mic. Yeah, so we'll anonymize this. Yeah.
Are there any people at the moment, or is it just not?
All right, we're back in the room. So, yeah, we're going to hold off on the stealth until he has a chance to anonymize the CT scan. But in the meantime, we can take off the drape. Okay, great. So right after surgery, typically people go home the day after surgery after this. If they're kind of in their mid-70s with Parkinson's, we might keep them for an extra night. Not much pain. The pacemaker that we implant a couple weeks later is really what delivers the therapy. But just like how this operation evolved from ablations, destructive procedures on the brain, even the microtrauma from the operation can sometimes result in what we call the honeymoon effect, where after the operation, their symptoms may improve, albeit temporarily, just as a result of the micro swelling that is a reaction to placing the wire. But yeah, typically people go home, morning after surgery. So the programming is kind of an iterative process, meaning that because especially with Parkinson's, where you can lower medication, you kind of take. And I think we can go back to stealth. We're good on stealth now. You kind of take 2 steps forward, 1 step back as you advance the DBS therapy, but reduce the medication. So we usually counsel patients. They can be 3 to 6 months. It really depends. Sometimes it's less time, but especially if someone's on high doses of medication, it may take several, 3 to 6 months to kind of fine tune that. Just because otherwise it can be kind of a roller coaster, dropping medications overnight and then trying to rebuild with DBS. Okay, yeah, so on the stealth, you can see here on the upper right corner, you can show. So those are the 4 contacts you see here. So we're at the second contact from the bottom, which is the contact I target when I target subthalamic nucleus. And we have different dimensions that we look at this. And here we see a 0.4 millimeter error. So that's great. That's what we're looking at, 0.5. So that's relative, and you can open up, that one. And then relative to the surrounding structures, now we're turning on the MRI. We're right at the kind of outer half. If you look at that subthalamic nucleus at a 45-degree angle, we're on the, that looks just right. You can scroll up and down on that. Actually, use the arrows because the scroll goes 1 millimeter at a time. So structurally, that looks good. And then so far as where I intended to go, based upon my coordinates, it looks good. So we're 0.5 millimeter off, and that's our cue to proceed with closing. So kind of our average is about 0.9 millimeter error. Our threshold is usually about 2 millimeters, but if anatomically, relative to the surrounding structures, it still looks a little bit too close to something or too far away from something else, we will reposition. And repositioning occurs, maybe 1 time out of 20 to 1 time out of 30 of these wires that we put in. So this little thing I'm putting on here, that's we call it the boot in the boot cover. It's basically a covering of the electrodes. You can actually see 3 of the electrodes right here, and the 4th one is being secured by the boot, and that's the tail end. And this is what's going to be, I'm going to remove this in a couple weeks, and that's where we're going to place and then I'm going to connect it to the secondary wire, the extension that goes down the neck. And that'll go down the neck to the chest where the internal pulse generator, the pacemaker, is placed. So I'm just securing this in place. Okay, that's it. Bayonet. So now I'm tucking this kind of above and toward the back of the ear. In preparation for next time, so I can manipulate it back here. It feels pretty good there. Okay. And now I tuck the redundant wire deep to this. And then we'll use the big blue wrench screwdriver to final tighten our little stim lock. Okay, looks good. Okay. Okay, looks good. Irrigation. And after our irrigation, we use our little pixie dust, which is a antibiotic powder, vancomycin powder. Good. Nice, healthy scalp. Okay. All right. And that's it. We're ready to close. So we're going to be using our little 4-0 Vicryls. Sometimes we'll see some bleeding at this point. Yep, fire away. So the role of DBS is really well defined. So it's not, it's no longer, it's not a treatment of last resort. It's not experimental. So I see it advancing in a few fronts. There's going to be utilization for existing indications. So that's Parkinson's disease, and I think that's what we're looking at so far as, kind of the way we do it here is very consistent. It's very much like the same operation each time, and that increases access of the therapy to patients. So increasing the penetrance of DBS for the existing indication of Parkinson's disease. Changes with the hardware. We now have 3 different devices on the market. That's competition. That just happened the last year and a half, where we went from having 1 manufacturer of DBS systems to having 3 manufacturers of DBS systems. So that's, and with that comes new technology, and it's a technology that we get to test and evaluate to see how it influences efficacy of therapy and convenience of therapy. I think the next step with that is also going to be miniaturization. Right now the battery goes in the chest. Are there better places? Can we have everything at the level of the head? So again, it may be the best therapy in the world, but if somebody doesn't want it done to them, they're not going to have it done to them. So I think miniaturization is going to be a key step. So all of this is kind of within the realms of how are we going to increase the penetrance within our existing population. The next one is going to be the new indication. So epilepsy is going to be the big next indication because they just got approval. So that'll be launching in the United States, I think, shortly. And that'll kind of change how people manage epilepsy. There have been a number of clinical trials looking at DBS for many indications: depression, Tourette's syndrome, and these are tough diseases to really validate in a clinical trial for FDA approval. But one thing that I'm really excited about is the potential for using DBS to modulate the cognitive circuits. So both in Parkinson's disease and, as we know, in Alzheimer's disease, the cognitive circuits can start to degenerate, and we're looking at using DBS to modulate the cognitive circuits. So the advanced trial was a trial we participated in where we basically stimulated the memory superhighway called the fornix. Let's see a snap. Plans are being undertaken right now to have the next phase of that study, which is going to be the advanced 2 trial, which would be like a phase 3 trial, evaluating the use of deep brain stimulation of a different circuit for the treatment of Alzheimer's disease. We're also doing a pilot study here looking at treating patients with Parkinson's disease who have cognitive impairment, looking at one of the memory nodes to modulate that circuit. Another area of interest is obesity. We know we can modulate appetite, and to see to what degree modulation of appetite, whether through the emotional circuits or through the satiety circuits, might affect obesity. So there's so many diseases that originate from dysregulation of neural circuitry. One colleague of mine said that anything that a stroke can help with, we think that DBS might be able to help with. So that's actually the case with things like depression, movement disorders. So that's one opinion, but we'll see. But yeah, it's the brain is just, it's all circuitry, and so all these circuits stand to be modulated. What the effect of modulation is what we're evaluating. But I think the areas I'm most excited about are the cognition, the possibility for obesity, increasing the penetrance for Parkinson's disease, because it is an underutilized therapy, and insurance recognizes that it's underutilized. All right. So that's the operation. We're going to undrape, and then he's going to get extubated and go to recovery. Do we have any other questions? Yep. Sure. Here, let me take a look at the stealth again. Yeah, so I think it's a pretty significant journey that a patient takes from the time they're, for example, diagnosed with Parkinson's. The same thing happens with essential tremor, right? People with essential tremor, which is again one of the other main indications for DBS, they might have this since they're in their teenage years. They're like, in high school they knew me as Shaky Joe, and then they show up in 40 years later, and they're looking into this therapy, and they're like, yeah, I heard about this 3 years ago. So it's a pretty significant journey to go from thinking this is something I live with to something I'm going to sign up for elective brain surgery for. And the FDA does have on their labeling for DBS, for Parkinson's, that it improves quality of life. So this is quality of life brain surgery. And that journey to say, look in the mirror and say, I'm going to go see a brain surgeon, and I'm going to sign up for having this implant in me for the rest of my life, is a pretty significant step. And I think that also kind of is what drives how the impact this has on patients, because it's obviously something that they're scared about, they think about a lot, they'd rather not have brain surgery, and then they get the therapy on board, and they have control of their body again. Their symptoms are not up and down throughout the day, and it's such a dramatic effect, and the discrepancy between the before and after and the decision-making process required makes such an impact on them, which is one of the reasons I find this an incredibly rewarding field and space to work in. There's so much to be done just by increasing the role of this in the everyday management of Parkinson's and tremor, and then beyond that, with epilepsy and the novel indications, makes this really one of the more exciting areas looking into the future for medicine, not just neurosurgery. So thanks for everyone who came to watch this, and we'll be waking our patient up and getting him to recovery shortly.